Thanks, Robin. Hey, Robin, welcome.
Hi, I didn't have the passcode. I'm sorry, it took me a minute.
Sorry, I know that's new. I feel like I think that was something we've only recently started having on there as the passcode, but glad you're able to join us. We are thrilled to have you guys here tonight, so thank you so much, and to everybody for taking the time out this afternoon. I was just telling folks that if they wouldn't mind putting their contact information in the chat box, you should be able to see that on the right, or if you might have to click that chat bubble on the bottom to get that to show up. But that way, especially for speakers, if you guys have questions for them directly or want to connect with other alumni after this conversation, it's nice to know who each other are and ways to connect with one another. So feel free to put your information there and where you work and what you do now and how you were alumni on the side. But I want to welcome everybody. We can go ahead and get started to our monthly alumni webinar. For those of you who have joined us before, I think, Sam, this is our 9th webinar series this year, which is exciting. It's something that we had kind of brainstormed as a way to figure out how we can still keep connected during the pandemic, and it's grown. So we have a decent number of folks who join us each month. And the goal of this truly is to just be interactive. We want people to bridge the gap between the main campus and the community and learn what UNC alumni and current faculty staff are doing so that we can refer to each other and understand what resources are out there. I don't know about you all, but oftentimes it can feel very busy in our line of work, and with clinical work and research, just there are plenty of things to do in our own lines. It's easy to get too caught up and siloed. So it's very helpful to know what all these other folks are doing and all the exciting research that's coming out of the department still. So tonight, given that it is Substance Abuse Awareness Month, October, the goal is that we really are highlighting substance abuse and what is the new data, what's the new information that we are working on it with UNC and how we can serve North Carolinians better in our goal to fight alcohol and opiate epidemics that we have. So I do want to introduce some of UNC's finest addiction specialists that we have here with us tonight. First up, we have Dr. Robin Jordan. She's a psychiatrist and assistant professor with the UNC Department of Psychiatry. She's the director of the UNC Addiction Medicine Program. And while I was still there back in 2018, she created the Addiction Medicine Fellowship, and in the same year introduced a peer support and Suboxone treatment program at UNC within the Department of Emergency Medicine, which is very necessary there. She's one of the prominent leaders, not only just at UNC, but honestly across North Carolina in terms of fighting against the opiate epidemic and being creative on how we can really access those who need this treatment most. Next up, we're also having Dr. Joyce Besh join us this evening, PhD. She's a researcher and a professor at the Bulls Center for Alcohol Studies. Dr. Besh's research program focuses mostly on the interaction between stress, behavioral pathologies, and the underlying neuroadaptations of alcohol use to better inform novel therapeutic treatments. So thank you so much for both of you for joining us and on all of us who are listening in tonight too. I'm glad to pass the presentation on over to Robin.
All right, well, what I put together today was some just general slides on the opioid epidemic and where the state stands with the epidemic. So I thought we would just open there, and then I know Joyce has a few things. I don't know if you have slides or not, but we'll turn it over to Joyce to talk about the her work, and then I think from there we'll just open up to general conversation. And some of our team members have joined this evening as well, and so I'll start with just introducing them, and so that the rest know they're from our team and can ask questions of them as well. So first there's Brenda, and maybe I'll ask y'all just introduce yourselves real quick. So Brenda, would you introduce yourself, please?
Hi, everybody. I'm Brenda Pearson. I'm a LCSW who has been working with Robin most gratefully for the last several years. I'm her project manager.
And Heather.
Hi, I'm Heather Connors. I'm the care coordinator in Dr. Jordan's Outpatient Addiction Medicine Clinic.
And Jerusha. Jerusha's mute. Just introduce yourself. Jerusha's brand new to our team.
Hey, my name is Jerusha. As Dr. Jordan said, I'm new to the team. I'll be working part inpatient and part outpatient, and I'm happy to have joined the team.
And Jerusha also has a lot of experience. She was a social worker at ADACT for many years. So a lot of experience in the field. So I'll go ahead and I'll share my screen now, and we'll talk about some opioid epidemic stuff. I can't share my screen. It's disabled.
I think Sam has to share it with you. Sam, do you mind giving her permission to share?
I think I just fixed it, sorry.
Oh, I can do it now. Okay, so let me get in presentation mode here. And I think this is swapped. Are y'all looking at the presenter view?
We're still looking at the regular view, I think.
Okay. And now are you seeing the presentation view? Okay, excellent. All right, so so sorry, there's a few extra slides here. The data that I'm going to show you comes from Department of Public Health. So these are their slides. This is public information. Anybody with any interest in the opioid epidemic should go here to learn what's going on. So this is just slides I pulled together from their website. So this is as of July 2021, where things stand with the epidemic. So the way we measure the epidemic is often through ED visits. ED visits we can track pretty fast. And so they look at opioid overdoses through ED visits. Mortality and overdose deaths, there's about a 2-year lag on that. So when we're wanting quick information, we can't rely on mortality data. So we look at ED visits and where the overdoses are occurring. So this is just all overdoses across the state. And we have these typical hotspots in our urban areas. Our area just showed up on the map this year. We never really showed up on the map before. It's just been within the last 12 months that we started showing up here. And so this is looking at overdoses per month, and the gray line is 2020. And so you see we had our overdose line here, January, February, March. And then you see from April to May, there was a pretty big jump in opioid overdoses. So we all know what was going on last year in this time frame of 2020. And the overdoses stayed high. So there's a little bit of a dip towards the end of the year, but still well above baseline. And then the green line is 2021. And unfortunately, I don't know, I haven't asked the state yet. I don't know what happened here, but they said they had some trouble gathering the data, so that these lines, these data points are not accurate. So chances are they're underestimated. But it looks like we're likely staying more in the 2020 trends. So we'll see, you know, as time progresses, what happens there. This is looking at overdoses over the years. And the dark green bar is the year-to-date bar. And this is as of July of 21. And so you'll see as of July of 21, here's 2020. And you'll see they didn't mark this here, but 2020 compared to 2019. So this was a 24% increase in opioid overdoses for 2020 compared to 2019. And then this is year to date. So July, as of July 21 compared to July of 2020, it says a positive 3% increase compared to July 2020. So it's thought we're either going to match 2020 or maybe be a little higher than 2020 for overdoses for 2021. So even though COVID happened, the overdoses haven't decreased since COVID happened. It's as if we have a new baseline for overdoses that we're working with right now. Hopefully we have a baseline. Hopefully it's not still increasing, but that's where we are. And this is looking at who is overdosing. So again, these are ED visits. And if you look by age group, so it's this 25 to 44-year-olds, mostly the 25 to 34-year-olds. This is who is primarily overdosing. So the light shaded bar is the percent of the population. So this is showing it's maybe 18% of the population is 25 to 34-year-olds, but yet they make up 40% of the overdoses. And then for 35 to 40-year-olds, maybe that's 15 or 18%, but they make up close to 30% of the overdoses. So it's definitely this young adult age group who are overdosing. And the population is largely white who are overdosing, and then largely self-pay or uninsured people who are showing up in the EDs with overdoses. And then this is looking at what they are overdosing on. And this is, you have to appreciate what they're looking at here. So thinking about if anybody's ever tried to gather data across the state. They're trying to get data from the EDs of what the people overdosed on, and the EDs everybody has their own screening methods. They all have their, their own ways of how they're documenting this. So, so you have to take that into account when you're looking at what this is. But they have heroin, and for our ED, we don't track heroin. So, I mean, that already shows you like it's a little bit skewed here, but you can see heroin, generally, if you look back to, that's August of 20, I guess this only goes back 1 year, but over time, because we only have this for 1 year, the number of heroin overdoses has decreased. And then you have this unspecified narcotics, and this is when the EDs just don't really specify what it is, which our ED would fall into this category. You don't actually know what it is. But then commonly prescribed opioids, a lot of EDs do have that, and that's a much smaller fraction for the commonly prescribed opioids. And then this purple category, they just started tracking this. So they just, in October, I guess, of 2020 is when they officially started tracking this, these fentanyl analogs. And I'm throwing this out there because it's a new term I'm hoping sticks, called fentanylogs. Because these fentanyl analogs are not the same thing as fentanyl. They are different from fentanyl. It's really important that we understand that they're not the same. So I hope fentanyl catches on because it suggests it's something different. But you'll see that these fentanylogs are increasing. It's a larger percentage is starting to show up. So this is what people are overdosing on. And that is it for what I have for data in the state. So I'll go ahead and stop there. Let me stop sharing. So that's where the state is with the opioid epidemic. So COVID absolutely had an impact, and we are still feeling that impact. So I'll stop there and turn it over to Joyce. And Joyce, you can fill us in on stuff y'all are doing.
Hi, everybody. It's great to be here. Thanks, Robin, for sharing all that. So just to give everybody a perspective of kind of where I'm coming from. So I am, as Rachel said, I work at the Bowl Center for Alcohol Studies, and I'm a professor in the psychiatry department. And at the Alcohol Center, we study various pathologies and molecular changes that happen that can potentially drive alcohol use disorders. So my lab is I'm a basic scientist, and my lab is using preclinical animal models to look at the consequences of stress on drinking and relapse. Okay, so it's very, very different. And, when we think about the impact of COVID on drinking, and I'm sure Robin and your group can, talk about this in a much better way than I can. But just in terms of what, published reports that are coming out, right? And we've all seen these like increases in drinking, rates of drinking have gone up, relapse has gone up. And, kind of what my lab is interested in is really trying to understand what drives those changes. So what changes have happened in the brain as a consequence of stress, right? That can put an individual perhaps just make an individual more susceptible to drinking. And so that's kind of the perspective that I'll bring tonight.
So that's all there's plenty that we can talk about. That's all I prepared slide-wise. So I think at this point we can just see what questions there are, what would y'all like to know more about, and we're happy to talk more.
We have a question, Dr. Jordan. For those who don't know me, I'm not an alumni, I'm not a provider. I am the typical person, I suppose. I'm the communications director for the department. My question is about fentanyl, and if someone dies of fentanyl while using, Xanax or cocaine or something like that, are those counted as overdoses even if the person didn't know that fentanyl was in it?
So the question, as I understand you saying, if somebody dies and they have overused fentanyl and benzos, is that still considered an overdose, even if it wasn't intentional? Is that what you're asking?
Yeah.
Or if they didn't know what all was in the drug? So yes, absolutely. So that's still considered an overdose. So there's intentional overdoses, which would be considered a suicide or a suicide attempt. And there's unintentional overdoses, which is what the bulk of these overdoses are. So somebody is using, they don't intend to overdose. They often don't know what's in the drugs. And that's gotten a lot worse since COVID has happened. So I'll share, because I just find this fascinating. I'll share a little bit of the recent history with the drug supply in the United States. So when the shutdowns occurred in March and April, one of the biggest shutdowns, if y'all remember way back when, was shutting down supplies from China. And as it turns out, a lot of our drug supply comes from China. And they really effectively shut down the drug supply from China. So we really didn't know what was going to happen. We're like, oh, maybe this will be good. You know, maybe there'll be less drugs and maybe that'll be a good thing. But unfortunately, Mexico caught on fast. And so Mexico said, well, this is our opportunity. And Mexico started very quickly synthesizing new fentanyl, these fentanylogs or fentanyl analogs. And it is not the same. It's just absolutely not the same as what was here beforehand. And they started synthesizing new methamphetamine, which is also not the same methamphetamine. This is not the methamphetamine that you make in your backyard or your bathroom that we had in the 90s. It is not the same. So this is new methamphetamine synthesized from Mexico that are analogs. And Mexico started bringing this. They had a free market now into the United States. So we started getting flooded with these fentanylogs and new methamphetamine. And that's when we started seeing overdoses really starting to increase. And so now we're dealing with new drugs that don't play by the same properties. We don't have the rule book yet. There's new rules and we don't have the book. And so for treatment, it's really complicating this for us. It's gotten a lot harder for us to do things we normally do because the drugs aren't the same anymore. So that's a big part of this epidemic and what's the opioid epidemic and what's driving these overdoses. So I guess part of that, Sam, what made me go down that path was Mexico brings in the fentanyl that has methamphetamine in it, and Mexico brings in methamphetamine that has fentanyl in it. And so it's difficult now to buy drugs and actually know what's in your drugs. So you can't just buy heroin. You can't just buy fentanyl. You're buying drugs that have any number of things in them. And people don't know what's in their drugs.
Right. Yeah, unfortunately, the reason I ask is because a very good friend of mine died in January from fentanyl. She had a problem with Xanax for a long time, but it took nothing. You know, let's just say she was using her regular dose. Almost, I know she did not try to overdose, and then, you know, that was that. I know that's been a really huge problem, especially where I'm from on Long Island. But thank you, that was interesting. I always wondered how that was counted, since it wasn't intentional.
Well, I'm sorry to hear that, Sam. And I mean, it just sucks. It just super sucks. And the story you describe is what we hear now. And people using things that they believe are safe, and it's not safe. I mean, it never was safe, but now today it's much, much less safe, much more dangerous than it was before.
Now they're pressing the pills to make it look like something else. Like even Adderall that you on the street now probably has a significant amount of fentanyl in it.
Yeah.
Your benzos, absolutely. And so last week, the DA actually came out and with a new, I don't want to say propaganda. That has a negative connotation, but a new saying one pill can kill. And the idea is that there's enough fentanyl or carfentanil derivatives in one pill that's pressed made to be look like a Xanax or an Adderall, and there's enough to kill an opioid naive patient. And I think that's a lot of the deaths we're seeing are also people who are opioid naive, who just are taking one pill and dying.
And oxycodone too. So they have these pill presses, they make them look like regular pills, and then the kids will pass them out of school not knowing what all they have in them, and they don't have oxycodone in them. And gummies, my kids get so tired of me for saying this, but there's gummies where they press gummies look like gummy worms, and they have various drugs in them, and they also have the dark web benzos. Like, this is for real, and they're giving them out of high school, passing them around. So kids need to not take anything from anybody, because it really does take one pill is too much.
And it's especially the kids who are vulnerable because they don't have any tolerance build up. They're the ones who, one pill can be deadly.
Yeah.
What do the patients look like clinically who are out on these methalogs, compared to what they used to look like for you when they were just on the 90s version of methamphetamine?
Oh, for the methamphetamine?
Yeah.
The methalogs. All right.
Yeah.
Well, I like that too. So I think for the methamphetamine, the urban areas, we didn't see a lot of methamphetamine. So the methamphetamine was primarily in the rural areas. And a lot of people with methamphetamine use just don't come to treatment. We don't have medications for it. A lot of people with methamphetamine use don't think it's a problem. So, so we really didn't see a lot of people with methamphetamine use. So now methamphetamine is in all of the drugs. So even people might intentionally use it, or they might not unknowingly use it. But now we see a lot of people with methamphetamine use who also have opioid use disorder, and that is something we just didn't see before. And then it's we see just a small number of people with methamphetamine alone who come to treatment, but a lot of people who use just methamphetamine just don't think it's a problem, and so we just don't see them as much. So I don't think I have a good knowledge base to compare the before and now for solely methamphetamine use, because the before was we didn't see them, and the now is we see them a lot.
And I understand some of them are psychotic once they come to your doors.
Yeah, so we definitely see a lot of substance-induced psychosis, and with the methamphetamine, you see a lot of this is typical of methamphetamines. You see a lot of sores on their faces, on their bodies. They think they have bugs inside their skin, and they scratch and scratch and scratch. But a big part of the problem as well is that we're getting so many more infections, and methamphetamine, I think, is part of the driver with that as well. But they'll get these sores and then they'll get infected. They won't seek medical attention, and they end up in our hospital with these very severe, serious infections. So, plus methamphetamine, they'll usually use IV, which is another big part of the problem. Methamphetamine, you can't snort it. They tell you like, oh, that's horrible, you don't want to snort it. You can smoke it, but they really prefer to use IV. And there's really this methamphetamine flood that we've gotten in the US has really increased IV drug use. So now people that may not have used IV drugs before, because they're using methamphetamine, they're using IV drugs now. And that's also driving our rates of endocarditis and osteomyelitis in the hospitals, and driving the deaths from substance use.
Robin, I have a question. When you're saying that these drugs now are just really different from a treatment perspective, how does that change the treatment? Does it just make it more difficult? Or, I mean, can you just talk about that a little?
Yeah, so we have medications for opioid use disorder, MOUD. So MAT is what people think of, but medication assisted treatment suggests that the treatment or therapy is the primary component and medications are secondary. And that's not what we believe. We believe the medications are primary. So we say MOUD, or medications for opioid use disorder. And so those are primarily Suboxone, Methadone, and Naltrexone. And someone has to be 7 to 10 days opioid free to be able to get on naltrexone or Vivitrol, which we don't see that population. Our population can't get 7 to 10 days opioid free. So methadone population goes to OTPs. Eric sees them. We don't see the patients on methadone. So our primary
Wait,
medicine.
what's OTP? Sorry.
The opioid treatment program.
Okay,
So
got it.
the old name was the methadone clinic, but now since they also can do buprenorphine, they're called OTPs. So we primarily prescribe Suboxone. So for us, getting somebody on Suboxone prior to a year ago was not hard to do. Someone comes to the clinic, they want to be on Suboxone. We say, wait until you're in withdrawal. Once you're in this much withdrawal, take this much Suboxone, come back next week. It was easy. It was very, very easy. And we've dealt with fentanyl for a while. So fentanyl's been around for a while. That didn't change things. You know, you have to get in this much withdrawal and then you start taking the Suboxone. Here's how much you take. My personal perspective was in March of 21 was when I saw things change. So I don't know exactly when things changed, but my perspective was March is when it changed. And all of a sudden we started precipitating withdrawal. So you give somebody buprenorphine, they're in enough withdrawal that you should be able to give them buprenorphine. And all of a sudden we precipitate withdrawal. So they're already in enough withdrawal. I don't know how familiar y'all are with this, but a CAL score of 12. Normally we do a CAL score of 8 was fine, but you wait for a CAL score of 12, you give them buprenorphine and their symptoms get way worse. You make their withdrawal really, really bad. And this just didn't used to happen before. So the position we're in now is if we want to start somebody on buprenorphine and they've been using these fentanyl analogs, we're almost at a loss of doing a standard induction in the outpatient setting. In the hospital, we're fine because we learned microdosing protocols. So we learned how to do new protocols. We learned this all last year using itty bitty doses of buprenorphine, and you slowly cross taper the buprenorphine and you cross taper the opioids they're on. We've gotten very good at that. So if they're in the hospital, we can microdose, no problem. If they're in the community, it's much more challenging to microdose in the community. We're trying macro dosing protocols where you start big doses of buprenorphine. We're just in this who knows what zone right now. We're just totally in this in-between zone. We're getting people onto Suboxone. It's just gotten really hard. And what's happening is patients are saying, I'm not going to do that. I've tried Suboxone, it precipitates withdrawal. The doctor gave it to me. They couldn't figure it out. And so you're getting more people now not wanting to get on life-saving medicine because it's too hard to get on it. So we got to figure this problem out soon, but we're in this middle ground right now where if somebody asks me how you start someone on Suboxone, my answer is right now, I don't know. Unfortunately, we're not good at it right now.
Robin, I have a quick piggyback question on that. So I know over the last couple of years, we have really been trying at UNC to encourage everybody under the sun to get their X number so that they can prescribe Suboxone. Do you feel like that has been helpful in getting people on Suboxone, or now are we unfortunately maybe not knowing how to prescribe it, and so we're scaring more people because it's being misprescribed or misused in some ways? Has that been an effective push? Are we seeing that more in primary care centers?
So we definitely, I think it's been very good. So we definitely have more providers getting X-waivered, and we still need more providers getting X-waivered. And so it's all good. We got a lot more people doing this work, all good stuff. We have more people precipitating withdrawal, but it doesn't mean you shouldn't get waivered, because we're going to figure this problem out and we're going to get there. We're just in a little bit of a weird period right now. So we're having providers precipitate withdrawal in the hospital. We've come in and we've learned how to do buprenorphine and opioids together. So we've learned these protocols of how to do this. So then other providers say, oh, well, I saw a patient on Suboxone and morphine and Dilaudid, so we can just do that. So we got other providers not really understanding the process in the hospital, precipitating withdrawal. So we're really just in this weird little zone right now. So people should still get waivered. We shouldn't stop that because we're going to get through it. But right now we're just in that zone of people should be reaching out and asking for help right now till we get this sorted out.
Another question I have, I was wondering if anybody could speak more on the treatment options that are available in terms of centers, providers that have space. Because I think it's something that I'm running into in the private practice world now is that I have folks that aren't necessarily heavy users that are dabbling, and there's a spectrum of use risk, right? But I still do really heavily worry about them and how that spectrum can very quickly slide into a scary direction. And I try to refer them out, and we run into these roadblocks of people are on large wait lists, or they're not appropriate for certain centers based on their limited risk profile in comparison to others. So do you guys have recommendations for those of us who are in the community who might not necessarily work with this population as our primary population, but see it quite often and want to encourage them to get help? Where do we begin in terms of like having our go-to resources in the major counties, at least locally?
So Heather, you want to tackle that one? Heather's like, don't ask me.
I knew you were gonna lob me with that. So I in our clinic, we do have like a limit. So we're taking the highest risk for overdose death. So unfortunately, occasionally I do have to give people other resources. You know, I can't guarantee that what they'll say, but hopefully they can get help. We refer a lot of people to Eleanor Health. They do virtual visits, and they have offices all over the state. If people have private insurance and certain Medicaid. We work closely with FQHCs in our area, but I can't really refer people there because they have such limited space and they take our patients. But if I refer the whole community there, they won't have room for our patients anymore. So uninsured folks often, you know, there's the OTPs that they can go to. They have grants that they can see people who are uninsured. But other than that, there's not a lot of options.
So this is where we need more providers doing the work. So people reach out, and I don't like that our criteria is highest risk of death. That's just horrible. It just shouldn't be that way. Everybody who wants access to treatment should be able to access treatment. But that's not the place we live in today. So I guess we lost Rachel there. Oh, there you are. But our criteria right now is highest risk of death. So we take people out of the hospital, out of the emergency room, out of detox centers. That's what the literature tells us as people highest risk of death. And we're working on our referral process from the prison. And then we have our spokes that we work with, and we'll take people from our spokes. We've been able to maintain our referral sources up until March of 21. March, April, we got squished, and we can no longer even meet that demand. But we've sorted it out now. We got some more fellows, and we're okay now. But the demand of people who are in severe need is just incredibly high. So we need a lot more providers who can do the basic maintenance work. And so we don't mind stabilizing people, but we need the providers who can do the basic work so that we can refer them to those providers. So providing basic addiction care it just has to be the job of every outpatient provider, whether you're a peds provider, whether you're a psychiatrist, whether you're primary care, OB-GYN, it really doesn't matter. It has to be the basic language of every person providing general care in the outpatient community. So there has to be some level of knowledge in treating basic addiction, or we're never going to be able to get on top of this. The specialists, we have specialists, we need more specialists, but we need non-specialists to be able to do this. I'm sorry, Jerusha.
About further treatment, I came from a place whereas we had them for 14 days. I previously worked at ADAC in Butner. We had them for 14 days. There are quite a few inpatient providers, but the key is them meeting their criteria. And sometimes they want people to come from an inpatient facility to potentially be eligible for their program. It just depends on that particular place. Like, for example, BATS in Winston-Salem, they only take people on methadone. And providers can refer them, but they're very stringent as well. We also relied a lot on the local management entity for each county Wake County was one of the really good ones that, in Sand Hills, that assist. Some of the other ones didn't do as well. So there is a lot out there, but a lot of times it's if they meet the criteria. And then sometimes if we get someone that's uninsured, it's like a hit or miss when you go to a particular program to try to get them in. So, you know, it's just sad that sometimes you'll have an individual that's ready and they're motivated, but some of their past history precludes them from being eligible for the program. So I just wanted to add that.
I'm not sure if Dr. Kashir or anybody else can speak on the alcohol component then. 'Cause I know that, I mean, it is a very different approach to treating somebody who is heavily addicted to opiates versus alcohol. And I think in my clinic, at least my practice during the pandemic has been that a majority of my patients are misusing alcohol as a way to cope when none of their other coping skills are maybe available as much as they used to be. So does that differ in terms of level? Again, the level of risk might vary there for sure, but in terms of referring out to community resources, I mean, historically, ASAP has been one of my go-tos, and so much of this is county dependent. The clients that I'm working with oftentimes are like working professionals, executives, parents, people who aren't, like, they don't see themselves in that class or that criteria of people who need those resources. So any advice or tips to encourage folks, not so much the medication management side, because I'm pretty comfortable with that, thanks to Robin Jordan in my training, but the therapeutic side, right? Seeing somebody weekly and having some accountability with this like CBT that's necessary for holding them true to the comorbidity of the anxiety that's correlated with their substance use. Referrals or thoughts on places that we can send those types of folks who need that therapy piece and might not need the entire program or might not be willing to accept it?
Well, LCASs. So in North Carolina, they're licensed clinical addiction specialists. So there are a good number of them in private practice. But then you also have SAIOPs that often do level 1 counseling as well. So First Step is a real popular one in North Carolina and the Triangle area, where they'll do level 1 counseling. And if they need a higher level of care, they can self-refer to that higher level of care. Fellowship Health Resources is another. I think Sigma is another. I'm trying to think what's in Chapel Hill. But if you're looking for a clinician, if you can find somebody with the LCAS behind their name, they're going to know how to do the motivational interviewing in alcohol use disorder. That's really important.
Yeah. The other thing I forgot to mention is, while Eric is talking about it, SAIOP, that's a good resource because that comes through the LME, that's state and county funds, for people who don't have any insurance at all. And once you get them connected, as he's saying, it has the SAIOP and it starts the therapy part as well as continue on with the medication. And we got Freedom House in Orange County.
That's right. And I think they do level 1 and SAIOP as well as inpatient.
Yes.
Yeah. So that is an excellent resource in Chapel. Yeah.
SAIOP is Substance Abuse Intensive Outpatient Program. So it's a thing, and it's 3 hours a day, 3 days a week is the minimum for therapy. So that's a higher level of therapy. But what they're saying is programs that offer that would also have lower levels of therapy for people that don't want that intensive therapy or don't need that intensive level of therapy.
And we shouldn't forget about self-help groups either. They're still not as effective as meds, but you know, not just AA, but also Smart Recovery, Celebrate Recovery, Rational Recovery. You know, I rarely recommend that as a sole form of treatment, but it's still extremely helpful.
So I would like to use this opportunity to talk to our psychiatry friends about things that all of us can do to pay attention and have an impact. And so there are areas, things that you can do without prescribing medications, but still be involved. And one thing right now, as Rachel, as you mentioned, alcohol is going way up. And also methamphetamine, as I said, I mean, Mark just flooded with methamphetamine. So if you're getting patients where anxiety is really high, your medications aren't working, you might want to do a tox screen and look for methamphetamine, because methamphetamine is out there a lot. We went from 10% of our population having methamphetamine use to 40% of our population having methamphetamine use in 1 year. So, so for general psychiatrists, you might want to be doing some tox screening, because methamphetamine may be underlying your insomnia and anxiety complaints. The other thing is infections from IV drug use are skyrocketing. And so hepatitis A, so we already were in a hepatitis A outbreak in North Carolina, but as of, it was March 2020 and then April 2020, it just skyrocketed and stayed high. So hepatitis A, we're in a big outbreak now. And hepatitis C, we've been in a big outbreak and we just still are with hepatitis C. Hepatitis C is just, we diagnose hepatitis C all the time. Those are easy areas for anyone who uses drugs. They don't have to use IV drugs. Anyone who uses drugs needs to be tested for hepatitis A, hepatitis B, hepatitis C, HIV, syphilis. Anybody who uses drugs, so not IV, because they will use dollar bills to roll up their drugs. They'll share that with each other. They'll share their pipes that they smoke with. And these are ways that you can transmit these infections that aren't IV drugs. So, and they won't always tell you they're using IV drugs. So anybody that you know is using drugs, you need to be getting screening. So Hep A and Hep B, you need to screen for those, because we can vaccinate for those. And the vaccination, honestly, is confusing. I tried to do it myself. When I looked, I was like, what? There's like 8 choices for a Hep A vaccine. Like, okay, I'm not doing this, but I can tell them to go to their primary care doctor and get their Hep A vaccine. And I can tell them to get their Hep B vaccine. So we need to be screening for those and get our patients vaccinated. Hep C, there's curative treatment for Hep C. And if you screen your patients, you're going to find patients with Hep C. It just, you will. So they need to be referred for treatment for Hep C. HIV, fortunately, has not gone up. So HIV, we're good, but you still need to add it on if you're screening. Syphilis, we started, I just wasn't paying attention and we weren't doing a good job screening for syphilis. And it was maybe 3 weeks ago that I started telling our team, we need to be adding syphilis on. And right after I said that, we have a patient in the hospital right now, 30-year-old guy with neurosyphilis who is now blind from his neurosyphilis. So horrible. So we must be screening for syphilis. So Hep A, Hep B, HIV, Hep C, syphilis. Those are things that all providers should be screening for. And if you know your person is active with drug use, they should be screened every 6 months, regardless if it's IV drug use or not. The other thing all providers can do is ask your patients, is there anything on your body that's a problem? Because a lot of our patients are getting these infections. They don't want to talk to their doctor about it. They don't want to show anybody. They're not treating their infections. And our rates of endocarditis are going way up. Osteomyelitis are going way up. And so the quicker we can catch on that they have an infection that doesn't look good, get them to their primary care doctor, sometimes urgent care, but you can just ask. They will actually tell you, maybe not all of them, but a lot of them will tell you. So those are some very basic things I think all providers can do that can have a big impact for public health. So I feel like we have dominated the conversation here, and Joyce has a lot of experience and wisdom to add for the alcohol world. So Joyce, is there anything you want to just pipe in on or contribute here?
I'm learning so much. I'm like taking notes as you're talking. I think, I mean, I don't know necessarily, you know, what to add, but, you know, I think just the kind of the impact of stress, right? that everyone has been experiencing to some degree, right? And as you've mentioned, Robin, I mean, just the impact of that is going to be very lasting. And I guess I just have a question kind of to throw back at you, but in terms of like from when the pandemic started to now, how have you seen alcohol related use like change, relapse change? Like how has that gotten worse? Has it gotten better?
Definitely not better. It's kind of interesting actually to me. So alcohol rates have definitely increased. So we know that for sure. We know there's a lot more people with alcohol use disorder who may have just been a casual alcohol drinker who have progressed now to alcohol use disorder. And we see that across the board, professionals, non-professionals, socioeconomic status does not matter. With the population we see for us in our clinic, we've not seen alcohol increase. So it's not necessarily our drug using population that has increased their alcohol use. It is others who have really increased their alcohol use. So we're going to see the downside, the downstream effects of this down the road where we get more of the complications that we see from alcohol use. So I think that is on the rise and rising. I think we're just at the beginning of what we're going to see from the alcohol problems. I see a couple of questions. I'm sorry I missed this in the chat. So what is typically the first step someone would take in the community to address their alcohol use? So I'll send that to our care coordinators if y'all, or Eric, if y'all want to answer that.
Eric, you can go ahead.
No, I mean, oftentimes, I get a lot of calls from the spouses or the boyfriends or the girlfriends, where they're trying to get their loved one into treatment for alcohol use. And they ask me that question. And, again, I usually recommend that they see an LCAS. I mean, I'm happy to see them, but depending on where they are in the stages of change, if they're pre-contemplation, don't waste $300 to see me. Start with an LCAS. Just ask them what they're willing to do. I think that a lot of people, statistically still speaking, start with an AA meeting. So they hopefully know someone who's in recovery who can bring them to a meeting. And hopefully, just listening to the stories oftentimes will help somebody, move to the next stage of change and maybe get close to preparation and, actually get treatment. So that's what I'm seeing is mostly it's the loved ones reaching out for help, not the individual.
Well, I would offer they can reach out to their doctor, whether that's their primary care doctor or their mental health provider, that they should at least reach out to their doctor and discuss what's going on. So the other question on here, has marijuana been found to be laced with methamphetamine? Everything has been found to be laced with everything. So yes, and I know that sucks. And back in the day, people be like, I don't know, maybe the cocaine was in my marijuana. And we're like, yeah, right. But today, yeah, anything you can find in your marijuana. So it is true, unfortunately. There is no safe drug anymore.
Yeah.
I would encourage psychiatrists who don't have addiction training to start with just buying a box of urine drug tests. You can easily go online and get they come in a box like this. And then, ask the patient to pee in it. And you'll be surprised at what you find. It's a great conversation. I like to keep one on my desk, just to ask, what are we going to find if you peed in this? You know, and if they, usually I don't even have to make them pee because they tell me what they're using because they know that's coming next. But so, you know, you buy a box and it'll last you a long time.
That's quite a persuasive tactic in person.
Yeah, yeah.
It's a virtual world. How can we?
I get them for about, you know, I get 25 for $75. So they're really cheap. They're like $3 a piece.
When we have patients who are being seen via telemedicine, though, sometimes those questions aren't as enticing because they're not going to go to a lab to get drug tested if they're trying to hide that from us, though. Any advice
Right.
for visits, pulling some of that information out more from folks who are pretty tightly.
Right. And I give them away for free to the loved ones. So for my telemedicine people, sometimes, you know, I'll ask the loved one, did they pee in the cup for me? What was the result? If they're a reliable loved one.
I think too, you have to kind of wonder why people are afraid to tell you those things. So if you are clear that there won't be consequences, or I'm not going to judge you, you know, it would just be a conversation starter. People are scared because they're afraid of your judgment. So if you're very clear that this is just, you know, something we're using to figure out what's going on, because you may not even know. We have a lot of patients who we do drug screens on and there's fentanyl in there and it scares them. So it might be something that they would be interested in.
Hello, may I ask a question?
Please.
It's so good to see Robin and Eric and Rachel. So good to see you guys. And I'm sorry I was a little bit late. So this may have been something that has already been addressed. But with the education, are you seeing as many kind of iatrogenic exposures to opioids, or are doctors doing a better job of trying to use alternatives, or are you still seeing a fair number of the initial introduction of prescription?
Now that's improved a lot. And I've watched it improve. I've watched it from when we started, and I would call a surgeon and say, this person's going to have surgery. We need to minimize their opioids. And they still give them huge prescriptions. Then the pendulum swung, and then we went too far where no one wanted to prescribe opioids and they could have surgery and still not get opioids. So we kind of went too far. I think now we're settling a little bit better where people are willing to prescribe opioids, but we're not seeing the over-prescribing. And UNC has done a really, really good job with their de-prescribing efforts. So they really have tackled this and developed new protocols. They've streamlined Epic, where Epic won't allow you to prescribe these large amounts. Epic will default to very small amounts of opioids. So they really have done a good job within UNC to promote opioid de-prescribing. So I don't think that that's the big contributor at this point. I think at this point, the cat's out of the bag, and now the drugs are out there, and that's what we're seeing.
Are you getting a lot of inquiry about how to manage pain in patients who are being treated for opioid use disorders, and managing surgical pain and that sort of thing?
Yeah, I don't know that that's necessarily changed. I feel like that's kind of always been the case. And historically, our response has been, we are not pain doctors. You will very likely get pain relief from the things that we do. But our purpose is not pain. Our purpose is treating the use disorder. But if you continue to have pain beyond what we're doing, then we would refer you to the pain doctor. But usually if we treat their depression and their opioid use disorder, their pain gets a lot better. So it's still a big, pain management, we say we don't do it, but really we do. And a lot of the patients we see have pain complaints.
Rachel, is that one of your future psychiatrists with you?
My coworker. I knew at 5:30, we got lucky I made it this far. I had a really quick question come up actually, and this is on benzos, which we haven't touched on a whole lot yet. I recently learned, a patient taught me about these scripts you can order online for microdosing. It seems like it's a smart thing if we could employ that kind of more globally, but it seems like only a couple companies online do this. And so I'm a little bit concerned about using those, obviously. So I've just been, following action protocols close to possible and piecing it together however we can with the patient. But have you guys heard of those before? Benzo taper strips, where they're like micro dosing of the benzodiazepines?
No, I don't trust anything benzos and web related because anytime you start buying stuff on the dark web, it's bad news. So
Well, dark, I'll have to look it up and maybe I'll send it to you, but it's not dark web. It's a pharmacist that does that. And I believe it's stateside. I don't think it was from Canada at all, but it was the idea of, you know, how you can dilute prescription medications in water and then like piece it out so that very small dosages to taper on. I think this company or this pharmacy has done that, but made it into a strip formulation, which very enticing for my patient who didn't want to have to chip away at small 0.25 milligram doses of things, but I didn't trust it, so we did the chipping away.
yeah, I don't know about this, so I can't speak to that.
There are some compound pharmacies that will give you lower dose benzos if you're, you know, because I don't understand why the smallest dose of a Klonopin is a 0.5.
I agree. Yeah.
I mean, why isn't there a 0.25? I got one patient. I don't prescribe benzos because I trained under Bert Hutto. But yeah, trying to get somebody off that last half milligram of Klonopin would be a lot easier if there are smaller doses to then lean to. And you know, oftentimes I'll use a longer acting benzo to wean somebody off a shorter acting benzo, but you know, using if you can't, oftentimes getting a high quality pill cutter is really helpful. But there are some compound pharmacies they'll make you smaller doses for that, for the very end of that taper.
Perfect. Thank you all so much. Any other questions before we wrap up? I know it's getting to be some people's dinner time, and I'm sure on your end as well. Any other last minute questions, or other people who are treating clients in the community who you have services to offer that I can refer to you, availabilities or anything like that? Otherwise, thank you all so much for being here tonight. This is such an important issue and one that I'm seeing so much in the community more and more every day. And I know the training that I received while I was at UNC is spectacular. And if I struggle, I can only imagine how much the average person out there is struggling in terms of helping these patients out. So I appreciate you all so much and helping inform and educate us to keep this care as good as it needs to be in the community to help people out. Thank you all so much again.
Thank you all for being
All
here.
right, thank you, everybody.
And Dr. Bashir. Have a great night.